going on very quickly, we will be introducing our speakers for today. And like I mentioned earlier, we have 3 speakers today. We will have 2 of our speakers take the didactic session. We've broken that into 2 parts. And then we'll have our 3rd speaker help navigate and coordinate the case presentation. These are seasoned experts who are across different, who have different key interests in this topic, who have worked extensively within this space. Our first speaker is Professor Emmanuel Ejim. He's a professor of medicine and consultant cardiologist of the Department of Medicine at University of Nigeria Teaching Hospital in Enugu State. I don't know if anybody is on the call from the University of Nigeria. Maybe you attended or you're currently attending. Please feel free to rep your school in the chat. He's done extensive work within this field, and he has contributed to over 50 published publications in the field of cardiology. So this is something that he has, this is his passion. We'll go very quickly into our second speaker. Our second speaker is Professor Ifeoma Ulasi, who is a professor of medicine at the College of Medicine, University of Nigeria, and has affiliations with several hospitals. So for those of you who know UNTH or EAFETH, she has affiliations that I'm sure you must have heard of her. She's an international advisor of the Royal College of Physicians in London. She's a member of the WHO Task Force on Organ Donation and Transplantation. She's a past president of the Nephrology Association of Nigeria, former council member who representing Africa and the Middle East in the Transplantation Society. That's a very key aspect of this work, especially for people of Black origin. To be very active in this space. So we're talking about someone who has extensive knowledge and a passion for the discussion that we have today. She's part of the executive committee of ISN, the ISN ESCOM 2021 to 2023, a member of the review team of KDIGO guidelines. She's involved in several research initiatives and projects in kidney disease and non-communicable diseases. So of course, it's a no-brainer that we have her here. She's a side PI of the H3 Africa Kidney Disease Research Network and PI of the Health, Hereditary and Environmental Research Institute. She's an associate editor of the American Journal of Kidney Disease and Transplants International Journals. She has been an examiner of the West Africa College of Physicians Postgraduate Medical College for about 20 years. She teaches medical students, student nurses, and supervises postgraduate students and resident doctors. So please, a round of applause for Professor Professor Ejim and Professor Ulasi. Please, I want to see the hands clapping in the chat. You better clap before they change their minds. And then our 3rd speaker is Dr. Abimbola Opadeyi, who is a consultant physician and clinical psychologist. She's a fellow of both the West African College of Physicians and the National Postgraduate Medical College of Nigeria. Her research interests are mainly in the areas of pharmacovigilance, pharmacoepidemiology, clinical toxicology, rational use of medicines, and hypertension. So you see why when I say that we have people whose passion and interest are in this field, I wasn't joking. She has over 20 scientific publications and presentations and has conducted research in hypertension medicines management, evaluating pharmacovigilance systems and interventions to increase adverse drug reaction reporting among healthcare professionals in Nigeria. That's a very key aspect of the work that we do and the discussion that we want to have today. She was a member of the drafting committee of Nigeria Hypertension Society 2020 Hypertension Guidelines and a former treasurer of the Nigerian Hypertension Society. She is a senior lecturer at the University of Benin. She teaches clinical students, pharmacology and pharmacovigilance, as well as bedside teaching in internal medicine. She also serves as an external examiner to the West African College of Physicians in the Faculty of Internal Medicine. So please, a round of applause for Dr. Abimbola Opadeyi as well in the chat. please feel free to give her a round of applause. I think we have one of our speakers who is having network challenges with joining, but I think we can go on. Dr. Olasi, Dr. Ejim, I think is having some network difficulty, but I think we can continue just so that we make sure that we are using our time properly. What are you okay with that, Ma?
Yes, I am. I am. I guess when he comes on, he can give his own perspective because we kind of tell us two together.
Yes. Okay. So would you want to start off with his own information, or should we jump straight to yours?
Okay, I could speak to his, and then. Or do you want me to speak to his since he can't join?
Yes. I think when he joins, we can then he can take over.
Mine, then he can speak to his because it's unfair.
So I think we can start with his because it gives like an overview of the entire session.
Yes, that's what it does actually.
Yes.
Okay.
Yes. So
so can we have the first slide? I'm speaking on for Professor Ejim, who both of us are talking on complications of antihypertensive drug therapy. Before I start my talk, I want to thank the organizers and actually congratulate you for this particular idea of having us teach some other professionals that work with us in this field of health. Because obviously doctors, nurses, or pharmacists, on all others cannot fulfill the number of patients that have hypertension, taking care of them. So it is worth our while that we inform other health workers that can help us take care of patients. So next slide.
Okay, I think he just joined. I think he has.
Okay, wonderful.
Here. Yes.
Okay.
Let me see if he can hear us. Good afternoon, Professor Ejim. Can you hear us? Hello, sir. Can you hear us now? Oh, his audio is still connecting. Let me see if we can help with that. Okay, I think he's here now. Yes. Sir, can you hear us? Hi, Prof. Professor Ejim, can you hear us now?
I can hear you now. I'm sorry. Okay. I've had some emergency. Sorry about that.
No problem at all. Okay,
that's very good. Professor Ejim, are you at UNTH? Or you're outside? That's probably why you're having the issues.
Do I start presenting?
Yes, sir. You can go ahead. Okay. Can you hear? Well, you can hear us, right?
Yes.
Hi, Prof. Can you hear us?
I can hear you. Can you hear me?
Yes. Okay. Yes. Please go ahead, sir.
Okay.
Can you see the screen?
Identification and the management of side effects. There's nothing to declare. Next.
Hello, sir. Can you hear us? Because we can't hear you.
Okay, let me get my mic.
Okay, so we just give Professor Ejim a couple of seconds so that we see if we can hear him clearly. These things happen with technology, so please bear with us.
Can you hear me now?
Yes, sir.
Okay. That's okay. Okay, so
okay, so we can't hear you anymore.
Okay, let me try another network.
Hello, sir. Can you
Can you hear
hear
me?
us?
I can hear you, yeah.
Okay, please go ahead, sir.
I don't know what it is. Okay.
Okay, so I think we would have to go, Professor Olassi, I think we'll have to go to yours just so that we can maximize the time and then give Professor Ejim time to adjust his audio, and then we'll come back to him, if that's okay.
I think the problem is where he's cited. If he has the University of Nigeria Teaching Hospital, the network is terrible there. So if he's there, it will be a problem. Okay, so my name is Ifeoma Olassi, as already have been introduced, and I'm going to talk on complications of antihypertensive drug therapy. My talk should have come after Professor Jim's talk, which kind of gives us an overview, a broader overview, while I delve down into some of the more little details. Next slide. Do I have control? So our learning objectives after this 30 minutes is to see that we understand that any medicine can cause unwanted side effects. And then we also need to understand how the different medicines, antihypertensive in this case, work in the body. And we need to also know how the body deals with the medications after they've done their work. We need to be able to recognize and differentiate the side effects of medications or effects of excess medications, and when to involve other professionals, when we need to go to the next step. Next slide. So generally, I mean, if you take antihypertensives or antidiabetics or whatever medicines you take, you could have problems, and a list of problems can occur, like because you're on several medications, you may even, or somebody may even prescribe a medication that you don't need, or you may take the medication wrongly, or take a wrong medication for a different thing. Or you can take too low a dose or too high a dose, and of course you can have a drug reaction, or even inappropriate adherence. These are problems we have when we're on medications, and they dovetail into either side effects or overdose or drug-drug interaction. Next slide.
Hi, Prof. Would you like to try, let's see if we can work with your video.
Okay. You want my video on?
Yes, ma'am.
Okay.
Yes.
Yes, my video is on now.
Yes.
So coming to side effects and toxic effects, we need to differentiate between the two. These effects happen when we take drugs. When you take your medication, we are hoping that we have a desirable side effect at the therapeutic dose. And because drugs act all over the body, they just don't go singling out where you have the problem to act. You have other undesirable side effects. And the undesirable side effects can be undesirable effects can be effects you have even when you take the normal therapeutic dose, which is what we call side effects. But when you go on and take overdose, or the drugs accumulate after you have taken therapeutic dose for a long while, you can have what we call toxic effects. So they're a bit different. Next slide. So a drug has a main salutary effect, like I've explained. And in doing that salutary effect, it may also exhibit a different effect, which I've explained that we call side effects. And then side effects of antihypertensive medications are many, and that depends on the type. We'll see that later in one of the studies done in Uniben. I'm happy that Dr. Kwemi is from Uniben. I'm sure she knew when that study was done, or she knows about that study. It could be severe in some cases, necessitating stopping the medication. Next slide. So there are various antihypertensive classes. When I started medicine, the hypertensive classes, I'm not sure, were more than 4 or 5, but I mean, with the development, we are developing newer and newer and newer drugs, that we have more than 10 subclasses of antihypertensives we can use, ranging from the diuretics, calcium channel blockers we know, ACEIs we know, ARBs we know, beta blockers, vasodilators, central agonists. Those ones are like aldomet and clonidine that we use, or alpha blockers like prazosin or doxazosin that we use, or alpha receptor agonists like recepine, or combined alpha and beta blockers like labetalol or cannabidiol, and renin inhibitors. Those ones are new. Next slide. So for us to understand what the medicine does to the body, which is basically looking at what actions they do, the mechanism of action, we have simplified it for understanding. Thiazides and thiazide-like diuretics, what they do is that they stop sodium. Sodium is salt, from being absorbed in the kidney. This is usually done at a part of the kidney that is the distal tubule. And what it results is flushing a lot of water out and salt. Once you excrete salt, salt will go with water. And by doing so, you will bring down the blood pressure, because salt and water are the things that keep the blood pressure high. Loop diuretics also work by reducing sodium, but they work at a different level of the kidney. Then we have the potassium sparing diuretics. These ones, what they do is to combat some substance that is also produced in the kidney, the aldosterone, and stop them from acting. Aldosterone will increase sodium reabsorption, but so they inhibit aldosterone and make it, and we now lose sodium instead of increasing their absorption. And then in exchange, we take in potassium and hydrogen. So in effect, such a drug will cause high potassium if we don't take care. Calcium channel blockers, there are two types. One type, that is the dihydropyridine type. Those ones act more on the vessels and cause what we call peripheral dilatation. That is relaxing the muscles of the vessels, thereby reducing blood pressure. Or the other non-dihydropyridines, that's the amlodipine and nifedipine group. They reduce the force of contraction, all in the bid to reduce blood pressure. Next slide. Still talking about mechanism. We're looking at ACE inhibitors because I know we use ACE inhibitors a lot here. I think it's one of the medications they are using by the federal government. That is the losartan, I think. Or losartan, ARBs. We use ARBs. But apart from ARBs that we are using by the government, I know that lisinopril is used everywhere. It's so prolifically used in fact, many patients know about it and it's so cheap. So what they do actually is to block the formation of angiotensin. Angiotensin is one of these substances that help us tense the muscle of the vessels. By so doing, they will reduce the blood pressure. But on the other hand, they also increase a substance that we call kinin. Kinin on its own causes vasodilatation, so it will help reduce blood pressure, but it's also a source of complication. You will see, well, because of it and the increase in another substance that is called substance P, patients that are on ACE inhibitors may have cough because they have this irritating cough. It's because of the increased kinin and substance P in the chest. That is what is causing that. And ARBs, that is angiotensin receptor blockers, they block the receptor so that angiotensin 2 cannot attach. That is that substance that tenses the muscle cannot attach. By so doing, they reduce blood pressure. These do not affect kinin, so they don't have that side effect of cough. We have beta blockers. There are mainly two types of beta blocker. There's a third one. The beta blocker, three types of beta receptors in the body. One is the beta 1 receptors, two is beta 2 receptors, and they are located in different places. Mainly in the heart, we have beta 1 receptors, and then in the lungs and the chest, we have beta 2. There's the third one that is not significant for us here. What happens is that if you have a drug, a beta blocker that selectively works on beta 1, it will have effect on the heart. But if you have one that works on both 1 and 2, it will have an effect on the heart and on the chest. And the effect on the chest we don't like, because it reduces the epinephrine. That's epinephrine is while in the vessel and the heart, it increases pumping. In the lungs, it helps us dilate our bronchioles. So if you have it not being there, such people are now prone to bronchospasm and asthma. So it's a side effect of taking beta blockers, especially the ones that have beta 1, beta 2. So that's the cardioselective types, atenolol and metoprolol. We also have combined alpha and beta blockers, which are like labetalol and carvedilol. These are quite effective. Most cardiologists, I'm not a cardiologist, I'm a nephrologist. They use it in hypertensive crisis, and we use a lot of. We are not afraid of using antihypertensives. Nephrologists are the people that you will see put their patients on 4, 5 different antihypertensives to bring down the blood pressure. But this is not the level for where we are at now. So next slide, we are talking about hypertension per se, simple hypertension. So we also have vasodilators. These are hydralazine, minoxidil. They relax, what they do is to relax the muscle. They relax the tension in the muscle. So by so doing, they reduce blood pressure. I've mentioned the centrally acting, the alpha methyl dopa and clonidine. They act centrally to reduce the peripheral resistance and blood pressure. And I've also mentioned the alpha blockers. This is where alpha 1 blockers, this is where you have doxazocin and prazosin. The importance of this is that in patients who have BPH and have hypertension, you may well put your patient on prazosin and this because they help reduce the BPH. So you see where you have some synergism because of the side effect or the side advantage of the drug. Okay, also peripheral adrenergic inhibitors like reserpine. I'm sure people remember reserpine of old. I remember when I was a resident some 20, 30 years ago, we used to use Brenadine a whole lot, and Brenadine contains 3 different molecules in it. So then the last one is renin-angiotensin, the renin inhibitors. They are a new group of drugs. Example is aliskiren. We don't have much of it here. But if you notice, I've been talking about angiotensin group. Renin they all work in the same chain or in the same pathway. Renin is the thing that breaks angiotensinogen that we produce in the liver into angiotensin 1. This angiotensin 1 is now acted upon by the angiotensin converting enzyme and changes it to angiotensin 2. So you see where the different drugs work on. I look at it as an example of where somebody wants to make soup. You have to get your money, go to market, buy your stuff, buy all the things you need and come back and make it. If you don't have money, that's one way of stopping you doing it. If you have money, you get to market, it is not there. That's another way of stopping it, you doing it. Or you don't have transport. So this is the way these medications work. They work at different levels of the pathway to affect to have the effect we want in reducing blood pressure. Next slide. So how does the body deal with the medicines? First of all, for the medicine to work, it has to be absorbed. It has to go to the cells where they need it. So whether you take it orally or IM or subcut, they have to be absorbed into the system. And when they are absorbed, they have to be distributed all over the body. And of course, we all know the best means of distribution in our body is the bloodstream. It carries it all over the whole place. So for example, a medicine can have an effect in one site that is salutary, but in the other site, it may be a problem causing side effect. Let's take an example of a pain reliever. You've taken NSAID, Indocin, for pain in your leg or sore muscle. Of course, it will heal that sore muscle, but meanwhile, in your stomach, it irritates your stomach and causes gastritis or pain. So this is how, just to give you an example of how side effects come about, because the drug don't just go to one place and locate, they go all over the body. Next slide. And then the next thing they do, of course, is to metabolize the drug after it has done its job of treating or working on the part it's supposed to work on. And this metabolism is done in the liver, mostly in the liver. After, and what it essentially does is to break it down and make it more inactive, that it stops working. And the next step is excretion, either through the kidneys or through the GI, through phases. Next slide. So this is the study that was done in the pharmacology and therapeutics units, Okoyemi's unit in Uniben. I don't know if she was out. That was 2017, so you should know about it, Okoyemi. This was done in 2017. They decided to look at their patients who were on antihypertensives and what side effects they had. So they noticed that 93 out of the 514 patients they saw, which is about 18 or close to 20%, had side effects. Most of the side effects were from diuretics. Understandable, because most of the times we put our patients on diuretics. The other one that was important was calcium channel blockers. We use calcium channel blockers a lot in blacks because our hypertension seems to be responsive to it. They respond to it quite a bit. ACEIs are also used. So these were the ones that compose the main causes of side effects for their patients. And they noticed that almost half patients had to discontinue or substitute their medication. So side effect is clear, it is there. But of course, that does not stop us from managing our patients. We just need to know that there are these side effects and that there are alternative drugs to use. And then we look at this, you saw what they showed, that side effects are of course more as the number of drugs you give increase. Next slide. And this one shows the different systems that are involved, and they seem to be the renal and urinary system that is mostly involved. And you have about 32% and respiratory about 16%. And the range of frequency of symptoms, they found that a lot of them had the frequency of micturition, understandable from the diuretics, poor erectile function, about 65%, of course, is mainly men. So headaches and reduced sexual urge, they all go together. Poor erectile and reduced sexual urge probably go together. Insomnia, weakness, and all that. Cough, we mentioned cough and what ACEIs do. Fatigue, and all the way down, the different things they noted. You will notice they put dizziness on standing and dizziness not related to posture. All this may probably be related to hypotension. Next slide. And then the next thing is that they looked at what their patients did when they had the side effects. So for those on calcium channel blockers, they even had frequency of micturition, and I'm like wondering how that happens. And then dizziness, headaches, and other side effects. And what did their patients do? 10 discontinued, and 11 reduced, and some 4 did nothing. You can see the different, for angiotensin converting enzyme, you can see again, dry cough was more, dizziness, diarrhea, and all that, and what the patients did. Okay, next slide, and all the way down. So that we can, how am I doing with time? So what do you now do when your patients come with side effects? First of all, you have to be sure that the patient does have the side effects. So you have to ask for the symptoms. You have to know the medications the patient is on. And also you have to check adherence. Talking about knowing the medications your patient is on, I was just talking the other day about a patient I have who was on several drugs, including pioglitazone. And his heart function was good. Kidney function was not too bad. He kept complaining of weakness. He did not have hypothyroidism. Excessive weakness that, that's the first thing we'll tell you about. So we decided to look through his drugs to find out why. And then to our surprise, we found out that pioglitazone causes this extreme weakness that you cannot explain. We removed pioglitazone. Within 2 days, the man was up and doing, no more weakness. It shows you the importance of taking history and looking at the medications of your patient when they complain. Don't assume some of these things because some people talk of neurosis. and anxiety neurosis or whatever neurosis. Before you can talk about neurosis in your patient, you must rule out physical thing going on. Okay. So, and for the examination, of course, you have to look at the vital signs, take the BP and see for those that have, in fact, for all of them, if the patient complains of postural drop, you take it lying down and standing, check for edema, check the skin for skin rash. For this level, first of all, you reassure your patient so you don't get your patient all flustered. In some cases, just reassurance because some of the side effects phase off in time. You can also reduce the medication or alter the medication. You can discontinue some medications and change to another antihypertensive. You see, we have so many classes. And then if you can refer the patient. Next slide, please. So the other thing I want to talk about is contraindications. We need to know that medications we give, at times we have contraindications. There's not every medication we give to everybody. People that have hypersensitivity or allergy, you have to be very cautious with giving them certain drugs like ACEIs. They cause angioneurotic edema. And this angioneurotic edema can be life-threatening in some cases. So you have to find out if the person has any allergy to medications, any form of allergy. The thiazide type diuretics, they can, we nephrologists, we don't use it in patients who have anuric or have poor renal function because it doesn't work to start with. You're just belaboring the person with medications that won't work. For a patient that has liver disease or liver failure, you have to be cautious with using thiazide and loop diuretics. At this level, I would suggest you don't go using it. The experts who can monitor it can use it. Beta blockers are not used in patients with asthma because you will precipitate asthma. Minoxidil, ACEIs, and ARBs are not used in pregnant women and breastfeeding females. Potassium sparing diuretics are not used in patients who have CKD because you start off hyperkalemia. You know, they have problem with excreting the potassium they have already. And then alpha blockers are not used in those with history of hypotension or orthostatic hypotension. Next slide. So toxicity, we talked about side effect and we talked about toxicity. Toxicity occurs when you have an overdose or when you have been taking the medication for a long time at the therapeutic range. I recall sometime a close relation of mine went for surgery. He had been on nifedipine and thiazide for a long time. I'm not sure we checked his potassium. After the surgery, he had severe hypokalemia. Severe hypokalemia because he had been on thiazide for so long. So we had to drop thiazide. So you see, when you take a medication for so long, even patients that go on NSAIDs because they have joint pain and leg pain and take it for a long time, it destroys the kidney. Or paracetamol that destroys the liver. So thiazide diuretics and loop diuretics can also cause electrolytes abnormalities, hypokalemia, hyponatremia, and all that. You know that the toxicity is a stretch far more than the side effects. The same thing with the potassium sparing diuretics, they cause hyperkalemia. We've had that in side effect. In this one, it will be worse. I also talked about a man who had what we call adult polycystic kidney disease and was seeing the doctor, and they had done this serum urea and electrolytes for him. The potassium came back 7. The lab person did not ring a bell. The doctor that saw did not ring a bell. The young man called me and said the father had potassium of 7. I said it can't be. That if he has potassium of 7, he cannot be alive with us. He said the father was with him. I said you have to get your father straight to hospital. I don't know if the result is right or wrong, but let's check it, because if it's wrong, the effect can be lethal. Within 30 minutes, called me back that the father was gone. So hyperkalemia is a no-no, is a terrible thing. They just killed him. The father was gone within 30 minutes. So for the non-dihydropyridines, this is amlodipine, they can cause bradycardia and hypotension from what we talked about where they act. while the dihydropyridines will cause vasodilatation and severe hypotension. I think I've mentioned the toxicity from ACEIs and ARBs, severe hypotension, hyperkalemia, and hyponatremia. Beta blockers will cause bradycardia and hypotension. Next slide. I think that will be probably my last slide. Okay. So, okay, this slide talks about monitoring. We've talked about all these things, side effects, toxicity. What it tells us is that our patients who are on medication must be monitored, especially if there are medications we know that can cause serious side effects. Like we have to monitor potassium in our patients who are on ACEIs. Monitor potassium in our patients who are on thiazide. I gave you 2 examples already. Monitor uric acid in our patients who are on thiazide and loop diuretics, because we know that they can have hyperuricemia and it can precipitate gout in some patients. Our patients who are on loop diuretics, you have to monitor the ear. It causes deafness. Those days we used to give high doses of furosemide. We had a lot of patients who had deafness. Hypertension and edema will occur with dihydropyridine CCBs. I've mentioned those with the side effects. And I explained to you that we need to monitor all these things so that we don't, your patient, you need to check the pulse, make sure your patient doesn't have, for beta blockers, yes, we want to beta block, but below 60 and your patient has symptoms, it's no. You have to change the drug or you have to reduce the dose. Tachyarrhythmias and orthostatic hypotension in patients with on alpha blockers, and then some patients on hydralazine could have autoimmune disease. We know that it causes it, and could have changes in their full blood count. Next slide. Next slide talks essentially about the drug-drug interactions we can have. We can look at some of these drugs. When you give atenolol and amlodipine, it can cause increased risk of hypertension. Atenolol plus telmisartan, they can have increased potassium, hyperkalemia. One thing we have to understand is many of these drugs have different points of action. That some we know, some we don't know. So atenolol and nicardipine, which is a calcium channel blocker, can cause increased risk of hypertension. But in some cases, we combine 2 different drugs to augment our treatment. They are synergistic, like when we have furosemide and telmisartan, or furosemide and ARBs or ACEIs. They help, the furosemide will reduce the potassium that ACEIs will increase. And so you are not afraid of hyperkalemia in such cases when you use such drugs. So they work synergistically. The same thing with the furosemide and spironolactone. While spironolactone will increase potassium, furosemide will reduce potassium, and so on and so forth. Next slide. So essentially, this is probably my last slide. The other issues we want to talk about is adherence. Adherence is so key. And one thing I've noticed about our patients is that a good number of them don't adhere, especially when they are on medications that are expensive. Instead of putting a patient on a medication that is expensive and he doesn't take it, the best thing is to use the cheaper one. Side effects at times make them not to adhere because they feel that if I take it, I will have hypotension, or if I feel it, I will have erectile dysfunction and all. So the best thing for us to do in such cases, we have to cancel them, change the medication to another one so that we'll get them better, because there's no point asking him to take it to him. He won't take those drugs and he won't be well controlled. I think, next slide. Okay, so I will stop so far. Thank you for listening. My take-home message is one. I've said it that, I don't know if I mentioned it here. Every drug is a poison. Every medicine we take is a poison. The dose and the amount and how we take it is what differentiates it from being a poison and a medication. We need to understand that our patients that are on drugs would have side effects because drugs act in all over the body. In some parts, you have the salutary effects you want. In another part, you may have the side effect. But side effects can be managed, or we can change to another medication. So, and I also have put you through understanding what the drug does to the body and how the body handles the drug. I hope you have learned one or two things from this talk. Thank you for listening.
Thank you so much, Professor Olase. That was really, really insightful. Like she said, let's be very clear, even when we talk to our patients and counsel our patients around taking their medicine, because if they take the wrong dosage, then it defeats the good intent that the medicine was created to achieve. I think we have Professor Ejim back. I don't know if you can hear us now. Professor Ejim, can you hear us now?
Yeah, I can hear you. I've changed my network.
Oh, wonderful. Okay, so we will go. Professor Ejim is just going to give us some part of the overview, just piggybacking on some of the information that Professor Olase has shared with us. Over to you, sir.
Okay. Thank you very much. So I will stop at the outline. Next slide, please. So hypertension, I'm sure, had been defined for you people by Dr. Oji. I looked at his lectures. If somebody's BP is up to or above 140 systolic and or 90 diastolic, or if the person is using antihypertensive medications, you say the person is hypertensive. And the choice of this value is because from this value and above, the chances of having maybe a heart attack or a stroke or kidney problem or dementia or vascular problems, they get higher. So that's why that's the reason for choosing this level as the cutoff mark for blood pressure. In the past, it was higher, but recently it has come down to 140 over 90 as the definition. Next slide. So this classic definition is based on BP measured in the hospital or the clinic or the wards, because you can also measure BP at home. And a lot of studies in the past done were on the risk of hypertension and the problems associated with it are based on blood pressures measured in the hospitals or measured in the offices. However, sometimes BPs measured in the offices may not really reflect the true blood pressure of the individual, because some people, when they come to hospital, they may be wondering, out of anxiety or some other things, wondering, what this blood pressure, what is going to be today? So the person's BP may go up just because of his presence in the hospital. And we call it white coat effect or white coat hypertension. This person ordinarily doesn't have a high blood pressure. But if he comes into the hospital, his BP goes up and you measure and you see that it's high, it may be misled to treat the person for high blood pressure, which will now cause hypertension when he gets home. Conversely, some other people, when they come to hospital, their BP may normalize. But when they go home, the BP goes up. This one is actually more dangerous because when the person comes, you be deceived that this person doesn't have high blood pressure. So you may not bother treating. When he goes home, the BP goes up and the person may have a stroke at home. So we call this one mask hypertension. So like a high blood pressure wearing a mask, so you don't see it. Next. So because of these variations, that because of these phenomena, both white coat effect and mass hypertension, there may be a need for BP to be measured either at home or over 24 hours. Although if you want to know whether somebody really has mass hypertension or somebody has white coat hypertension, you may need to measure the person's blood pressure over 24 hours. There's something called ambulatory blood pressure monitoring, where you attach a cuff to the person's arm and then give a small recorder which records the blood pressure every 30 minutes or every 1 hour over 24 hours. That gives a better idea of the person's blood pressure, true blood pressure, and also helps to find out those who have white coat hypertension and those who have mass hypertension. And recent studies have shown that BP measured over 24 hours is more accurate in predicting death and illness from cardiovascular disease compared to BP measured only in the clinic or in the office or in the hospital. Next. So these are the different definitions of blood pressure depending on the type of BP you have measured. So if you have measured the blood pressure in the office, if it's up to or above 140 over 90, that person is hypertensive. If you measured it in the house, maybe you're in your home, measuring blood pressure. If you get values of up to 135 over 85 and above, then you're hypertensive. If these BP recordings are the ones you do in your house, then if you do 24-hour blood pressure monitoring, then a blood pressure of 130/80 and above also defines hypertension. If it's done only at night when you are asleep, if it's up to 120/70 or above, that makes you hypertensive, even though it is 120/70. Then if it's done in the daytime when you are awake for ambulatory blood pressure, it is same 135/85, just like the one done in the house. Next. So I'm sure Dr. Oji had told you about how to measure blood pressure. If somebody just walks into your clinic or health center or wherever, you don't just measure the BP as soon as the person walks in. You need to give the person some time to rest so that things can calm down. The person needs to be comfortably seated, and the arm where you're going to measure tie the cuff should be resting on a table of appropriate height so that the person doesn't have to stretch his hand to put his hand inside your cuff. Then the person will also be resting his back on something so that the person is relaxed. The important thing, the person should be relaxed while the BP is being measured. The person should not have taken alcohol and should have taken caffeine prior to this measurement. And then the individual should not be talking while you're doing the blood pressure. And then the cuff size should be appropriate. If you use a large cuff size for a small arm, it will give you inaccurate values. If you use a small cuff for a large arm, it will do the same thing. And there's no point tying a cuff and then holding it. Sometimes these people who are measuring blood pressure, they tie the cuff and the cuff is about to pull out. They now use their hand to support it. That you're not measuring the person's blood pressure. You're measuring something else. Then digital machines are very good machines for measuring blood pressure. They're even better than the manual machines. But sometimes people feel that the digital ones give errors and all that. But one good thing about them, they eliminate the observer error. Because if I measure somebody's blood pressure and you can get differences, because maybe the way I'm looking at it, I may have parallax errors while I'm looking at the machine. You may also have parallax errors. So digital machine tend to eliminate observer error that we see with manual machines. Next slide, please. So in terms of epidemiology, that's hypertension for us here in Nigeria is the commonest non-communicable disease. If you take away illnesses caused by infection and genetic things, hypertension is the most common thing that causes illnesses in Nigeria. And the prevalence in Nigeria when the BP was when BP cutoff was 165/95, that's in 1997, it was about 11.5. So if you get 100 adults, 11 of them will be hypertensive by that time in 1997. But today, because the cutoff value for hypertension has changed, so if you get 100 men with 100 adults, for instance, that about 20 of them may be hypertensive, using a blood pressure cutoff of 140/90. And also in Nigeria, we know that hypertension is more prevalent in urban areas than in rural areas. It may not be the same in some other places in Africa. Next slide. Then again, currently the prevalence in different places depending on the study that was done and the population used. In some places, the prevalence is up to 46%. I mean, so if you get 100 people in some places, up to 46 of them may have hypertension, and this is worrisome. And then some of our colleagues had observed that most of the complications of hypertension, including the strokes, encephalopathy, kidney failure, heart failure, could actually be avoided if these people are properly treated. Next slide, please. So when we talk about hypertension, like I mentioned, there's some people, if hypertension were not to be causing complications, it wouldn't be a disease. So the primary aim of asking people to take BP medicines is to prevent these complications. These are actually the things that make hypertension a problem. Because if you were not causing brain hemorrhage or stroke, or causing heart attack, or causing dementia, or causing heart failure, or causing limb gangrene, or causing blindness, or causing chronic kidney problems, or causing eclampsia in women, in pregnant women, there will be an illness. So these are actually the things that make hypertension an illness. And these are the reasons why people are asked to take medications to prevent any of this from happening. Next. So in Nigeria here, there are about 7 classes of antihypertensive medications that are licensed for use. Professor Solas had mentioned some of them to you. The diuretics, there are many, the thiazide diuretics and the thiazide light, even the potassium sparing, they are licensed for use in Nigeria. the calcium channel blockers, the angiotensin converting enzyme inhibitors, the angiotensin receptor blockers, the alpha-1 receptor blockers, the beta adrenergic blockers, and the central acting agent. These are the medications licensed for use here in Nigeria. Next. Then the side effects of antibiotics, like last I mentioned, these side effects are class specific, depending on which molecule is involved. For instance, for individuals who are on antihypertensive medication, their greatest worry every time is we hear that hypotension can occur if you take hypertension, if you take BP medicines every day, and that hypertension is more dangerous than hypertension. Because this is because of the belief that they have that if you start taking a medicine, it keeps on accumulating in your body until one day it becomes so large that it will damage all the organs in the body. But only teach them that if you take a medicine by this period, now maybe it's past 3 in Nigeria, in the next 24 hours, you will have passed out most of these medications in your urine so that you wouldn't see significant trace of the medication in your body. So you need to take another medication to keep the blood level high enough to keep your BP normal. So it's not as if you take medicine today, it will wait in your blood, you take another one, it will add to that one, and then by the time you take it for 1 month, your body will be full of medication. That means medicines, as you take them, the body, because they are chemicals, the body destroys them, same way it destroys other things that get into it. After the drug must have done its work, it will be destroyed, and then, but you need to take more for you to maintain your blood pressure at the normal level it is. So, but hypertension could complicate any antihypertensive medication, but it is not as common as people fear that it is, because any medication that is an antihypertensive medication has a risk, there is a risk or that it could cause hypotension if it is taken excessively. However, unlike hypertension, hypotension has symptoms. The commonest is that if the person wants to get to the standing position, the person feels dizzy. So postural dizziness is an early symptom of hypotension, and if a patient is on medication and has that, you need to exclude that person has hypotension. Next. So hypotension could be confirmed by measuring the person's blood pressure. You could do it in the lying position and then maybe in the standing position if you want to confirm a postural drop. However, the absolute value for defining hypertension varies from individual to individual. It depends on the person's pre-treatment blood pressure. But the pre-treatment blood pressure and blood pressure level and the presence of postural symptoms or unexplained fatigue or sweating or blood vision could assist in categorizing. So if somebody is taking BP medicines and each time wants to get up, he feels dizzy, or he's getting weak, tired that cannot be explained, or he's sweating unnecessary sweating, or has blood vision, it will point to the fact that this person may actually be hypotensive. However, if the systolic blood pressure is less than 90, it may suggest the presence of hypertension in some individuals. Next.
Hi, sir. We have only 5 minutes more for your session so that we can move to the next as well.
Next, please. Next slide. Next slide. Next common side effect of hypertensive medications is erectile dysfunction. I'm sure Professor Lassie must have mentioned it to you. A lot of patients, can you go back, please? Go back to the other slide. Yes, a lot of men who are on BP medicine, this is their greatest worry. That if they start taking medications, they will have erectile dysfunction, and they would rather not take antihypertensive medication than have erectile dysfunction. So, but it is worse with some medications. Diuretics, ACE inhibitors, and the centrally acting agents are particularly notorious for erectile dysfunction. But there are some other medications that are neutral, that don't affect erectile function. Some even improve it. Valsartan, for instance, is known to improve erectile function. Prazosin is neutral on erectile function. Nebivolol does not affect erectile function. So these three have no effect on erectile function. Some can even make it better. So, and then the approach to treatment of erectile dysfunction in patients who have this, you need to weigh the benefit-risk ratio. You have to assess whether the person is only somebody who is dead from stroke or from heart attack or from aortic aneurysm and all that, cannot be talking about erectile function. So always talk about erectile dysfunction or want to be dead without talking about it. So if you check the risk benefit ratio, you don't know which one to. Next slide. So the first approach to managing hypertension from antihypertensive medication is to stop the medication. So if somebody is on BP medicines and there is evidence of hypertension, the first thing to do is to stop the medication. Then, depending on the class of medication, you don't know what next to do. Patients should be encouraged to lie in bed because these drugs have duration of action in the body. If you take a medicine that has a half-life of 12 hours, you ask the person to lie down in bed, don't go to any place. Within the next 6-7 hours, the effect of the drug may have worn out, and the person may be able to start going about his normal business. Other measures, like I said, will depend on the class of medication involved and its mechanism of action. Next. So let's now go to the specific side effects of different groups. The thiazide diuretics are very common agents in Nigeria. They are affordable, and they are potent as solo agents. They are effective as monotherapy, like I mentioned, and they're also affordable. So they're among the oldest medications in Nigeria and in many other African countries, partly because they are very, very affordable and they can work alone. I'm sure most of us know about moderatic, you know about diuretic, nomoretic, and all those. They are all diuretics. Their commonest side effect is that they can cause dehydration. That's the mechanism of causing hypotension. So they can cause thirst, cause dry mouth, and cause postural dizziness. If somebody has hypotension resulting from thiazide diuretic or from that, it may also require to do fluid replacement as part of the management protocol. Next. So apart from causing dehydration and all that, they can also cause hypokalemia. Dr. Thomas has mentioned that, which may manifest as muscle weakness, fatigue, and may have palpitation. Then you can use potassium supplements to prevent this, or you can use potassium sparing agents to prevent it from happening. So if somebody already has hypokalemia, you can give slow K tablets, most of them have potassium tablets, or you can give other medications like ACE inhibitors, ARBs, or spironolactone that will prevent this thing from happening. That's really the basis for combining thiazides and ACE inhibitors, or thiazides and ARBs, or thiazides and aldosterone antagonists. They tend to cancel out. This one causes hyperkalemia, the other one causes hypo. So the two will cancel out, and the patient will not have any side effect. Then thiazides also cause hyperuricemia. So uric acid is one of the products you get when you degrade purines. So it will lead to a type of arthritis called gout. And gout is characterized by painful, swollen joints, multiple joints swollen and painful at the same time. In the Caucasian world, it is common at the toes, but in our place, it also affects the large joints. And treatment of this type of arthritis, you are going to use agents that cause loss of uric acid in the urine, and also avoid other medications that can cause increase in the level of uric acid. Next. So the thiazides, because they're very common, we're going to talk about them a lot. They can also cause hyperglycemia. So they can make the blood sugar go up in somebody who is not hypertensive, who is not diabetic. But in diabetic patients, they can make blood sugar control more difficult. So at high doses, they should not be given to diabetic patients, but most times these days, give them very small doses, 12.5 milligram of hydrochlorothiazide, or 12.5 of clothalidone, or 1.25 of indapamide and all that. So, but at low doses, they may not have this side effect, but at standard and high doses, they can give them cause diabetes or make that blood glucose control more difficult. Then they also cause abnormal lipids. They can cause a rise in LDL cholesterol, and for all these ones, if they're caught, you have to withdraw the medication or use lower doses or use statins if the person has this lipidemia, depending on the benefits and the risk ratio. Next. Then the calcium channel blockers are also very common medications in Nigeria and in Africa generally. Group 1, they are effective as monotherapy, so you can give them alone, unlike other like ACE inhibitors and ARBs, which may not work alone in our people. And they're also affordable. People can afford them. They're relatively cheap compared to these other newer agents. But the commonest side effects they have are leg swelling and headache. And this headache sometimes could be troublesome. Sometimes it may not be clear-cut headache. The person may just be feeling somehow with the head. That something, this head is not correct. You're feeling unwell in the head somehow. So for these medications, they should be discontinued if these side effects are worrisome to the patient. Next. Then the beta blockers, they in the past, our people were not advised to give, they were claimed not to be very potent in our people, but it's not very true. Some of them actually work very well in our people, but like Professor Last mentioned, they could slow your heart rate, so the heart starts beating slower than maybe 60 per minute. They can cause spasm of the muscles in the lungs and can precipitate asthma or bronchospasm in non-asthmatic patients. They can cause sleepless nights. They can also cause high blood sugar. They can also cause abnormal lipids. They could make heart failure symptoms worse. And for these medications, they need to be withdrawn if anybody develops any of these symptoms. Some of them are safe in asthma, like nebivolol, but by and large, it's advised that you shouldn't give them to asthmatic patients if you have other alternatives. But when you cannot do without them, nebivolol is known to be safe in asthmatic patients. Next. Again, the centrally acting agents, they are also very old medications in our environments. They are potent as monotherapy. I'm sure some of you know about Brenadine, you may know about Risapine, I know about Adomet, and all these are very old medications that if you give given alone, they work. And for instance, in pregnancy, Adomet or alpha-methyldopa is still about the safest medications used by pregnant women. So apart from being relatively affordable, they work as monotherapy. Some of them are safe in pregnancy, but they have multiple side effects. They cause postural symptoms generally. Even clonidine is there, even though it's not very common in Nigeria. Then insomnia, they can cause depression. Of course, they cause decreased libido. And if any of these occurs, then you may need to change to more tolerable alternatives as indicated. Next. Then the ACE inhibitors, I'm sure Professor has mentioned, these are good medications because of their effect on the renin-angiotensin aldosterone axis. But the common side effect that they cause dry, irritating cough. The individual will be clearing his throat every time. The person wants to cough out, he can't cough out anything, but the throat is itching and all that. So that is their greatest problem. Like you mentioned, they can cause angioedema, which if it involves the face and neck, could actually lead to death by causing a respiratory obstruction or laryngeal edema and all that. They can cause high levels of potassium, as hyperkalemia. This could be prevented by combining ACE inhibitors with thiazide diuretics or thiazide-like diuretics or even with loop diuretics. So that's actually the basis, like I mentioned earlier on, for combining ACE inhibitors and ARBs with thiazide diuretics and thiazide-like. So they tend to cancel out. While the thiazides cause low potassium, the ACE inhibitors cause high potassium, and the two will cancel out, and the person will have a normal potassium. So these medications should be withdrawn if warranted in most of these cases. Next. Then the side effects of the alpha-1 blockers, where they are we use them a lot in Nigeria because people who have prostate problems benefit a lot from them. So if you give prazosin, for instance, somebody who has a prostate issue, that's a large prostate, apart from bringing down the blood pressure, it also tends to relax the muscles at the bladder neck so that the person can pass urine freely. So they're very useful medications, but they cause troublesome postural dizziness. They're about the ones that cause the most significant level of postural dizziness among patients, and they also cause leg swelling. But they are good medications, they are also affordable. Next. So in summary, the antihypertensive medications in current use are many, and they work through different mechanisms. They are useful in reducing disease and death from heart disease, brain disease, kidney disease, eye disease, and vessel disease. So blood pressure can affect all these structures and cause damage there, which can lead to severe illness or even to death. However, these medications have some side effects which may be intolerable in some patients. However, there are always alternative medications available for substitution of these intolerable ones, as long as the patient can afford it. So no patient should stop treatment for blood hypertension because of side effects from one medication, since there are potent alternatives. Thank you very much for listening, and sorry for the delay in starting the lecture. I had some issues with them.
No problem at all. Thank you so much, sir, for trying to change network so that we could get the meat of this lecture. Thank you so much. So we'll go very quickly, just because of time, we'll go very quickly into the case presentation. We would have, I think we have Mr. Emmanuel here to present very quickly. Mr. Emmanuel, please, you have 3 minutes to run through the case presentation so that we would have Dr. Pade give us some of her insights as well as her recommendations. But in the meantime, there are a number of questions. So Professor Olasi, Professor Ejim, there are questions in the chat, and we would appreciate if you can respond to some of them in the chat as well. And after the case presentation, we'll read out as many as have not been responded to. Okay, over to you. Mr. Emmanuel, can you hear us? Hello, Mr. Emmanuel, can you hear us?
Yes, I can hear you. Can you hear me?
Oh, yes, we can, loud and clear. Thank you very much. So please go ahead.
All right, good afternoon, everyone. My name is Emmanuel Zagi from Anagada PHC, Abuja. Next slide. Okay, case presentation. Name, Mr. AB. Age of patient is 64 years, and the sex is male. Occupation is farmer. The marital status is married. Religion is Muslim. Then race is Black. In what facility does the patient receive care? Anagada Primary Healthcare Center, Abuja FCT. Next slide. Clinical presentation. The patient presented in the clinic on the 6th February 2020 during a community outreach organized by the facility on hypertension. He had no symptoms and just took part in the outreach. His vital signs at presentation were as follows: blood pressure 175/102 millimeter per mercury, pulse rate was 90, first reading. Then 190/116 millimeter per mercury, pulse rate was 82 at the second reading. The client weight was 90 kg. The height is 163 meters. Then BMI at 33.9 kg. Next slide. Good. Case presentation. Management and follow-up. The client was taken to the hypertension unit to be enrolled into care. His management include counseling and drug administration. He was counseled on the following areas: activity to include exercise such as walking, swimming, or cycling in a weekly routine basis. Walking should be at least 30 minutes a day and 4 to 5 times a week. Then he was also advised on diet to reduce his salt and sugar intake. We advise the client to eat more, to go more on fruits and vegetables. Alcohol. He was encouraged to avoid alcohol. Tobacco. Also encouraged not to take anything containing tobacco. Medication adherence. He was also counseled on the importance of taking the medication daily as prescribed. Next slide. Other counseling include weight management. Since his BMI is already crossing the line for normal, he was placed on tablets, amlodipine, 10 milligram daily times 1 month, then losartan, 100 milligram daily times 1 month. He was asked to return for checkup in the 4 weeks' time. He has been keeping to his monthly appointments. Next slide. In case summary, Mr. AB has been our client for over 3 years. He has compiled and adhered with his medication and has been coming for his follow-up visit since then. Late last year, 19th November 2022, he complained of not being able to afford the medication prescribed for him. His medication was changed to tablet moderatic, aminoride 2.5 milligram, then hydrochlorothiazide 25 milligram once daily, which he used for 1 month. The next month, which was December 2022, He complained of constant headache, dizziness, and poor erection. After consultation, his medication was changed back to tablet amlodipine 10 milligram daily and tablet losartan 100 milligram daily. Since then, there has not been no side effects, has not been reported ever since. Next slide. Conclusion. In conclusion, changes his medication back to tablet amlodipine 10 milligram daily and tablet losartan 100 milligram daily helped stop the side effects he experienced. Thank you. Next slide.
Thank you so much. Thank you so much. So we'll give the floor to Dr. Paddy to give her feedback, her recommendations, and some thoughts around both this case and the case that she also wanted to cite as an example. Over to you, Dr. Paddy.
Thank you, Adora. So in case my network becomes too icky, then I can remove the video. So thank you all for coming to listen to this presentation. From this case that has been presented, young Pretty came for his clinic visits, had been doing well, but he complained that he didn't have enough funds to purchase the money. Now, cost is a major issue with that interferes with medication adherence. So they obliged him and they changed his medications. After I've listened to Professor Lassie and Professor Ejim, you saw that diuretics can cause erectile dysfunction. And thank you, Professor Lassie. That was our study, which we conducted then. And we found out that poor erection is a major cause of discontinuation. However, most men, they'll be reluctant sometimes to discuss it with female practitioners. So if they see a female healthcare provider, they'll be reluctant. But once they see a man or a male doctor or a male nurse, they are willing to, they're more open. So we usually would say, if you're starting a medicine that has the probability of having erectile dysfunction, just inform the patient ahead of time. This medicine may cause so and so adverse effects, may cause an unwanted effect in that you may not like. So if that does happen, please tell us. And then when they come back, we also do direct questioning. What did you use? How did you use it? What did you experience when you used this medicine and that medicine? So you see, they had to go back to his original medicine, which was amlodipine and losartan. Now, some of these medicines can be a bit costly. So the question you ask is, could he afford? He couldn't afford it, that's why they changed. Now that they have changed him back, can he still afford it? Maybe, maybe not. But in this case, you now have to explain to the patient, you can't compromise treating your hypertension because of cost. So you may have to forego a few other pleasures just to treat your hypertension. So this is key. You have to engage your patients one-on-one, and you have to see exactly the medications that they're using. We always ask them to come back with the medications that they have used and show us physically. Please, let's go to the next case. So again, we looked at overview. We're looking at what can antihypertensive medicines do when the drug becomes the problem. What then do you do? So this person, he didn't have any problem. So patients just go because they have malaria, and then they found out that they're hypertensive. Then you start them on medicine, and then they develop an adverse effect of the medicine. What do you do? Next slide. In every case, always remember that the patient is different. So we had this 60-year-old man, he'd been on follow-up at the clinic, and he had been on fairly normal drugs that you will encounter in a hypertension clinic. Amyloid hydrochloride is probably the most prescribed antihypertensive in Nigeria. Then lisinopril, and usually they will give a soluble aspirin. Soluble aspirin is not an antihypertensive per se, is used to make the blood flow a little bit more. It's an antiplatelet. Let's go to the next slide. So with this medicine, he started complaining. He had been on these medicines for 5 years, just believe me. And he started complaining of cough, which lasted for about 8 months. So he would complain of cough on and off, and it's dry irritating. So if you remember, one of the adverse effects from lisinopril is cough. So the physician examined, they didn't find any other thing wrong with him. And they said, oh, this must be a drug-related problem.
Hello, is it me?
No, it's not. I think no, it's not.
Okay.
Hi, Professor Lass. I think it was a network issue with Dr. Paddy, but she's back. Please go ahead, Dr. Paddy.
Sorry.
No
so
problem.
my network, in case it goes up, I may have to switch. Let me stop the video to help the network.
Yes, please.
With changing back to losartan and amlodipine, patients became fine. Sometimes we have patients who have cross-reactivity between lisinopril and the ACIs and the ARBs, but you just have to try to see if they can do well on these medicines before you decide, should I discontinue totally? Should I not give any drug that is related? Again, if you have patients who in the past, now patients have had previous experiences. So this is part of the question you must ask them. Have you used so and so medicines in the past? In our study, we found out that some patients had used, for example, nifedipine in the past, and they had tachycardia, they had palpitations. And now you are offering them amlodipine. You may have the same class-specific effect in the same patient. So it's always useful to ask what happened in the past. Next slide. What happened to the patient before this time? Then another patient, similar to the one that was presented, also, he had no problems, he had been on this drug, but it wasn't controlled. So it's medicine, especially alpha-methyl dopa. This was in the era when alpha-methyl dopa was being prescribed to men, and he came down with erectile dysfunction. And he went to, next slide. So he went to the pharmacy where we have a drugs poison and poison information and pharmacovigilance center to complain and said, look, I now have erectile dysfunction after they increased the dose. And this is why I'm emphasizing this. This is a multidisciplinary approach to managing hypertension. It doesn't always have to come back to the physician. Sometimes it may not get back to the physician. So what did they do? They looked at these medicines and said, oh, you have to go back to your physician. They have to review your medicine. This may likely be the cause. And they counsel him because this is a dedicated center where we give poison information, we give drugs information to both healthcare professionals and to patients. So in centers that have such setup, it's important to also direct your patients. In case you can't access the doctor, in case it's not your clinic day, don't just be suffering in silence. You can go to the Drugs and Poison Information Center where you can be given quality advice, and then you'll be attended. Next slide. So how then do you look out for adverse effects? How do you look out for these side effects which are unwanted? Because adverse effects are effects that you don't want from the drug. That's not your aim. So it could be that, for example, when we are giving diuretics, it's expected that the patient will pass urine. That's what it's worth. The diuretic means pass urine. So if you are giving a diuretic, patient will pass urine. But in a sense that the patient wakes up 10 times in the night to pass urine, that is an exaggerated effect. And as such, you have to address it. Otherwise, the patient will stop, say, this drug wants to kill me. So I had a 93-year-old woman call me and said, doctor, I took quarter of my drugs and I peed 5 times in the night. I'm not taking it anymore. 95, what do you want? 93, 90, what do you want to do? So you ask, please come back, let's review your medications and give you something else. Then sometimes you can predict that this will happen from the drug. And why is it important? If you can predict it, you can look at patient's circumstances and say, no, you don't need this particular medicine. We won't have to give you this. For example, we know that moderatic amyloride hydrochlorothiazide can cause erectile dysfunction. And if the patient has been pre-warned, immediately it happens, he probably would have presented like the very next day. So, but sometimes
You can't just explain that reaction. In such a case, what do? Just ask the patient, anything you feel from this medicine, come back and tell me. Next slide. So this is very important in counseling hypertensive patients. One, this is a long-term drug. So I'm going to share with you a series of reactions because from the Nigerian hypertension protocol, it's suggested that you start your patient on amlodipine and losartan. Now, amlodipine, when it was being trialed in Nigeria, one of the first studies that was done is a study from 1992. It showed that patients will pass urine frequently. And what did they tell you? Patients would come and tell us, look, when I take this medicine, I just keep passing urine, small, all the time. It's not a lot, but it's just disturbing. After some days, you stop them, it will come back. And this is very common. Of course, then their ankles will swell and they have poor erection, also with amlodipine. Next slide. Amlodipine is well tolerated other than this. So you have to explain to your patients when they do experience, they should come back. Then we looked at all the different drugs, and Professor Lassie has gone through this and told you frequent micturition. So probably we have to look again at the Black population and see why are we having such symptoms? Why do we kidneys pass a lot? Is it because we have a volume-dependent hypertension? So this is room for further research. Next slide. Again, we ask the patient, and this is where counseling also comes into play, like I said, what experiences have you had with your drugs? They complain of weakness, dizziness, impotence, and headaches. Headaches could be, some people tell you, when I have headaches, it means my blood pressure is high. And then others will come and tell you, when I have headaches, it means the drug bad. Change this drug for me. So these are questions that you can ask your patients. Some patients will not offer you these reactions. They rather wait to be asked. Next slide, please. So again, these are now newer studies. It's still the same problem, dry cough. A lot of the patients just think, oh, I have catarrh in my throat, it's not going. And they've taken a parcel of antibiotics. But really, it's the drug. Until some of them come with real bad facial swelling and they can't breathe, and then they realize that it's actually the drug. So we should, when you start a patient on an ACI, please look out for this dry cough, look out for facial swelling, lip swelling. Sometimes it's just the lips. And some patients have been having recurrent lip swelling over time. They don't ascribe it to the drug. Sometimes it's a rash. Professor Lassie mentioned that they can have bad rash, even to the ARBs. So ARBs have been found to be relatively safe, well tolerated, but they can still come down with rash. We've seen about 2 cases of patients that have very rash, very erythematous and pruritic rashes. So please look out for this when you start your patients on ARBs as well as calcium channel blockers. So what then do you do? Next slide. Next slide. How do you recognize the problem? One, if your patient is at risk, if your patient is asthmatic, you don't give some particular drug. Recognize those kinds of patients. Screen on medicines. Every medicine, we have patients who are on agbo, they're on herbal medications. If you ask them to come with it, they will come with it. That is why they are having the adverse effect. It's not necessarily the drug. So you have drug-drug interaction, you have drug-herb interaction, and you also have drug-food interaction. Somebody is on felodipine and is drinking grape juice in the night. Maybe the doctor just sent a carton. Think about it. That may be why the patient is having an adverse effect. Some patients take NSAIDs. NSAIDs are medicines used for pain, to relieve pain, but they can raise blood pressure. Some are on nasal decongestant. We know them, pseudoephedrine containing, and they can cause problems for the patient, in which the blood pressure will just rise astronomically. So please ask your patients what they are taking. Next one, next slide. Then patients, we have a lot of patients who have diabetes now, and don't always be so quick to ascribe your patient's problems to the other disease. Look at the drug. Some diseases mimic adverse reactions. If they discontinue their medicine, ask them why. If they reduce the dose, ask them why. Some people reduce the dose because they feel they will be hypertensive. Professor Jim mentioned this. They just think this blood pressure is too low. I will have problems from it. I don't want to be addicted to the medicine, so I will stop it. If your patient is complaining about different things, think, could it be a drug issue? If the lab results that they come with is abnormal, think Professor Elasi mentioned hyperkalemia. So think hyperkalemia, hyponatremia, hyperuricemia, abnormal lipids. These can all be drug related. Look at their diuretics, look at their beta blockers. These are drugs that can cause abnormal results. So just always look at the abnormal results. And always ask for class specific adverse effects from the patient. This has been discussed as well. Next slide. So if you go through just to highlight what will happen to the patient when they have consequences, what will happen if they have adverse effects, they can discontinue, they will not be adherent, they can have medication errors, and they can have hypertensive emergencies. So if they rush a patient into your facility and the blood pressure is 230, 150, 230, 120, also think, could this be that the patient suddenly stopped his medicine or added other things, or is on amphetamines? We have a lot of, I don't know how to call it in Igbo, that people are using crystal meth. And that could be why your patient is having a hypertensive emergency. Please look at that. Next slide. So if you just to summarize, because we are really out of time, first thing is make sure you screen all your patients. We usually ask them to come with their medicines. We look at the bags. We bring everything out. So you see medicine that was sent from abroad. Hey, my uncle sent this medicine to me. If it's not good for the patient, be bold enough to tell the patient, don't use this one. Then if you look also at the bags, ask them how they are using it. Some patients use 2 brands together. That could be the cause of their adverse effects. Always check their medicines when they come back for follow-up. And if you're not sure, start thinking, is it the kind of patient that will refer? These are the adverse effects from allopurinol. You can look at them later. Next slide. Also from losartan, just to highlight a few ones. Don't give losartan to a pregnant woman. Please, 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 please. Or a would-be pregnant lady. Try to avoid it. Also, don't give alcohol. Tell them not to stop. Some will never stop, but it doesn't matter. Anyway, just tell them. Next slide. And for everybody who has a reaction, please report it. There's no way we can have the kinds of reactions that are seen in Nigerians if healthcare workers do not report. So there are many ways you can report to NAFDAC. You can use this ADR form. Next slide. You can download the form, an app on Google Play. Most of us have smartphones now. Also thanks to cashless policy. Med Safety app, e-reporting. Go to NAFDAC website. You can get all of this and report. The more you report, then we can have a concrete database and tell us what the reaction was. How did it happen? When did it happen? What the drug was, and the details of the reporter. Next slide. Next slide. Next. And for a case like this, just looking at the multiple medicines patient on, you know what you do with that? This kind of patient, just refer to a hypertension specialist. Don't even bother to keep. Should you suspect any adverse reaction, just report it. Just report anything. Report it. If the patient says, when I take my medicine, I breathe too much, report it. Next slide. And then just refer to a specialist when a patient has multiple drug-related problems. The specialist has all the time in the world to sit down and look at the pharmacology of each and every single medicine. And that will just do the patient the best. And that will just be the best for the patient. Thank you. Next time, thank you for listening. Thank you very much.
Thank you so much, Dr. Pade. Thank you for the recommendations to the facilities and for even discussing some of the cases that you have also seen. We believe that using that model, it drives the message home for us, even as healthcare workers. Thank you so much.